Those who don't know, I'm Rob Nicolson. I'm a child psychiatrist here at CPRI. I want to be actually, I should have had Joan's name there, and I don't. And I apologize profoundly for that, Joan.
That's okay. I will not take it personally.
Please do. Also, I would also like to extend a special welcome now to Doctors Martini and Cheswick and Dr. Scanlon as well, the famous Dr. Scanlon, all of whom have taken the time out of their day to join us here. So what we wanted to talk about today was autism and attachment disorders. And I should preface it by saying that I think Joan and I have a lot of experience clinically in autism. Not sure either of us would call ourselves experts. And we've read about attachment disorder and have seen patients, but don't consider ourselves by any means particularly knowledgeable or expert about it. I think really what our goal today is to talk about a patient who we have, last years, who we have different opinions about. One of us is clearly correct, the other not. But sort of to talk about what the difficulties are that we have in this young man in terms of deciding what his underlying diagnosis is, and sort of walk through how we got to that. And as I say, we would like to make this as interactive as possible. So if people have comments, please feel free to do so. At the end, maybe what we can do is, if people have questions, they can email, they can, hang on a second here.
They can just put in the chat section, or they can ask themselves.
Sure. There we go. So first off, I have received research funding from the Ontario Brain Institute and Brain Canada, as well as from Hoffman LaRoche Limited. None of them will have any relevance or bearing on this talk. I guess, Joan, your only conflict is you're employed directly by the government of Ontario?
Well, I don't know that that's a conflict. That's a good thing.
Some might agree, some might not.
Oh, every now and then we got to remember that it's a good thing.
Sure. And this, for any reason, was something I found on the street outside a friend's house recently, which I was a bit puzzled by, and that's not of any direct relevance to anyone. We talk about attachment. I think it's been more and more recognized over the last 100 years or so. And I'm not going to review the history of it because I can't. But certainly, when I was a resident, one name that came up initially early on was Renee Spitz, who I believe was a psychoanalyst. And the story I read recently in this was that he became really interested in the idea of attachment and the effects of a lack of attachment on children after World War II whose parents had been killed in the bombing of London and who were in hospital. And he developed a term called anaclitic depression, which related to children who seemed to be had become institutionalized essentially and didn't seem to have any will, I suppose, to live. So he compared a group of children who were living in a nursery to children in a foundling home, which I guess was some more negative one, and found that children who were living in an area where they had their physical needs met, but not necessarily their emotional needs and the impact on their development and what that effect of not having somebody meet their emotional needs was. And he sort of came to realize that it had a significant impact on their development. His work was later followed by John Bowlby, who Joan came across a comment from Dr. Bowlby the other day, I believe. Joan, did you want to share Dr. Bowlby's opinions?
You know what, I don't have it handy, but I think the gist of what Dr. Bowlby said was that mothers should stay in the homes because they're the only ones that would care for their children, and other people who are caregivers would not care for them. So we have to take Dr. Bowlby, I think, with a grain of salt if we're going to pay too much attention to what he has to say, but I'm sure he was a little bit more successful academically than he was maybe in the social perception of mothers.
Except though I think he actually was talking about the importance of being with mothers. The way he wrote it may not have been ideal. I think in his quote, he talked about how women working outside of the home was a terribly controversial thing. And I think he implied that women working outside the home were doing essentially useless jobs that had no value to society. I think he talked about building widgets or something like that. And I think it would be difficult to write something like that in 2020. And he's been criticized, I think, rightly for that statement. I think he also recognized the importance of an attachment figure for children and for their development. Meow. and then with Harry Harlow with his monkeys, with the finding or with his research showing that they preferred a cloth monkey to a wire one, even if the wire monkey was the one that had the nutrition for them. And so really, there's a lot of questions that the idea of a chapter attachment raises that we can't actually address directly in research because it would be grossly unethical. But there are at times these what we call experience of nature, things that we couldn't do ethically as researchers, but somehow have happened anyway. So Nicolae Ceausescu was the dictator, a communist dictator in Romania. And Romania at the time, and I think even now, is a very, very poor country. I think when it entered the European Union in around 2007, I think it had the lowest annual GDP of any European Union country. And he, when he became dictator, he looked around at countries around the world that he thought were economically successful. And he recognized, or he thought he recognized, that they all had very large populations. And so the way he decided for a country to become successful economically was to have a large population. So he essentially outlawed abortion and birth control. I think women were not allowed to have abortions unless they had already reached the age of 40 and already had 4 children. Otherwise, they could not have an abortion. And at some point in time, I don't know what year it was, they actually started to tax families that had no children. So if you didn't have kids, you had a higher tax. And he felt that children were the property of the state, essentially, were also the responsibility of parents to produce. Romania was an incredibly poor country, as I said. And so what happened was we had these families who had very little money and very little resources, having many kids they really couldn't look after, particularly children with significant disabilities of any kind, whether it was emotional or physical. And so they ended up being dropped off at hospitals or orphanages. He was killed on Christmas Day, I think in around 1989 or 88, I'm not sure the exact year. And that's when sort of Romania opened up to news media from other countries. And what they found was that there were these orphanages around Romania where I think there was something like 150,000 children living in these orphanages when Ceausescu was killed. And they had, children in them had all their needs, physical needs met, although not very well, frankly, but they were at least fed and mostly clothed, but had very little in the way of emotional care. They weren't picked up, they weren't nurtured, they weren't held. And this became of interest to researchers afterwards because of what was the effect on that. There are, one of the great things about YouTube is that there are lots and lots of videos of things to look at historically. So I just want to show you what sort of the Romanian orphanages were like when they were first opened, when they were first seen by media from outside Romania. And obviously the boy we're going to talk about didn't face privations similar to this, but I'm going to talk about a little bit of research that's been done in this area and just give you a bit of a background. So these 2 videos actually come from 2020 in 1990. So anyway, so this is, it's about a man who was, had seen something on 2020 and he went there to try and help some kids. And basically there is, he and a Romanian doctor, I think, had sort of snuck in when people weren't looking. I guess I should say, I'm not sure if I'm obligated to provide trigger warnings, but what you'll see here is pretty horrific, frankly, and hard to imagine.
I don't know if that video is running for other people, Dr. Nicolson. On my end, I'm not getting anything except little screenshots.
Sorry?
I'm not getting the video. I'm just getting little screenshots. It's not streaming properly.
Can anybody see it apart from myself?
No, there's no sound, no voice, and it's just sort of like little, it's moving through its streaming just in frozen images.
Okay, I have no idea why. And so Mandy, when you say that you can see pieces, does that mean you can see the video or just without audio, or can you see anything besides pictures like right now?
She's
Or
seeing,
anybody else?
I'm just seeing changing frozen images. So it freezes and then it changes to another frozen image and then it changes to another frozen image, and there's not really any meaningful audio.
Well, meow, that might have something to do with the symbol I showed on the street at the beginning of the presentation. That group of people may be involved in this. So anyway, what this video goes on, and I don't consider myself a particularly overly emotional person, and it actually, some of the stuff that it shows, it's groups of children in this massive orphanages, sort of kept behind chain link fences, and within there, and sitting in a large room, and just many of them rocking back and forth. There's a couple of kids, but sort of classic, or what we think of as typical autistic, like finger mannerisms. But in one room, they showed a group of children who, half the group in this room, and it's about, it's going to be 50 or 60 children, half were sitting at a table eating, and the other half were, without clothes on, were sitting on the floor beside them, and there was, I think, like a plastic sheet underneath. They were all naked, so they were basically peeing on the floor or into buckets while the other half of the group ate. And the other video, so if you go on YouTube and just look up, well, it's a bit obscure, but 20/20 Shame of a Nation, I think was the name of it. It's actually quite horrific to watch. And it has implications in that, just to see what the effects of that are on development. So I will leave that for later for people to watch on their own time, I guess. What happened later on this, so a number of these children would later, Hugh Downs and Barbara Walsh were trying to barge in again. What happened was a number of these children were adopted into British families, I think is where they first noticed some interesting things about them. And someone who did a fair amount of research on them was Michael Rudder, who is a psychiatrist, and I think was actually the very first professor of child psychiatry in England, and has been at the Maudsley in London since 1965, and actually has a paper in PNAS this month. So what's that, 55 years later, 55 years later, sorry, still publishing, which is pretty impressive. But, and what they noticed was that some of the children, when they were adopted into households in England, appeared to have what they called quasi-autistic features, so that they didn't want to say it was autism because obviously their early development and their experiences were very different from other children's, but they had some features that were very strongly suggestive of autism in terms of their repetitive behaviors and their social interactions and communication. And in a paper published in 1999, what they did was they took 111 of these children who were adopted from Romania and then compared them to a group of children who were adopted in Britain also, but they were adopted from British households. So two groups of children who were both adopted. One group had this sort of horrific early life experience and profound deprivation. The other group had not. And what they found was that in the group from Romania, about between, I think around 6% of them had what they showed sort of what they called autistic-like or quasi-autistic behaviors, and another 6% of them showed individual traits of autism, but not anything that would add up to the whole syndrome. And they found that in the group that were adopted from English households or had been in England, that they found none of them had similar patterns. So more than 10% of the group from Romania had these sort of quasi-autistic features, but none from England did, which is obviously a difference, and it's hard to explain that other than the fact of their early experiences. It's a small sample. I suppose we could talk about other explanations, but it seemed unusual. They've continued to follow this group of people, and people in the United States are, as well as the Netherlands, I think, and they have reported as the group got older, what was interesting is that the children who were adopted before 6 months, that's a very young age, they tended to show much greater improvements in these autistic-like features, whereas those adopted after 6 months did not. And entering adulthood, they tend to still, especially the group adopted before 6 months, entering adulthood, they've shown significant gains, but still have problems, whereas the people adopted after 6 months had much greater difficulties They also report problems with attention deficit hyperactivity disorder in adulthood, much greater than you'd expect by chance alone. So a lot of really significant outcomes. And the reason, anyway, that I had talked to Joan about doing this presentation was this whole question of quasi-autistic features, meow, and what the implications of that might be, and early development. So let me just stop there for a second. Does anybody want to sort of comment? Anybody want to say more about the Romanians? There's many people, obviously, thousands probably know far more than I do. Any comments about that? Earlier this year, I was doing a presentation for second-year medical students, and the person at the back said, you always want to wait after asking a question. They suggested waiting 2 minutes after asking a question before moving on, even if there's silence. And I think that would be an excruciating 2 minutes, personally. But if nobody has any questions, then we can move on. So, first one we're going to talk about, who Joan and I disagree about in some regard, is a boy named John B. When we first saw him, what, a year and a half ago now?
Yeah, 2.5 years ago.
So at the time he was 5 years old. He was living with his father and his paternal grandmother. And it wasn't entirely clear how he'd actually come to live with them, as he had been with his mother before that. The Children's Aid Society had been involved in with his family since birth. And in part, it seems as though his mother had probably just felt that she couldn't look after him anymore and wanted the father and the grandmother to take care of him. But her plan eventually was to take custody of him again and have him live with her. So, and when we saw him, he was in what is now called kindergarten year 2, which everybody else is called senior kindergarten. So he was referred by a pediatrician, and the referring comment, the question was, does he have, he has behavioral problems, does he have autism? Was essentially it. So for assessments, we usually see people over 2 different appointments in order to sort of spend one appointment getting as much history as we can, and then a second appointment spending more time with the child directly, but they were there for both. Kid was there for both appointments. The father, John's father, reported that it was what he said was, quote, not necessarily a planned pregnancy. And there's a lot of contradictions. So initially, in what we have, the information we have says that mom didn't realize she was pregnant until about 5 months of gestation. But it was also reported that she had bleeding at what had been 4 weeks gestation and was told that she had miscarried. So I don't know if that means she knew she was pregnant but thought she had miscarried and didn't realize she was pregnant after that, or if she didn't know at all. There's a lot of confusion. Beyond that, the father and the grandmother reported that the mother was using intravenous opiates throughout pregnancy, and the pediatrician who referred John to us talked about the fact that mother was taking methadone during pregnancy. I was going to assume that she wasn't taking opiates and methadone, but I'm not sure. And the father and the grandmother also reported that whether she was taking opiates or methadone, intravenous opiates or methadone, it seemed pretty clear she was taking something. And according to father and grandmother, there was no plan for withdrawal or to help John through withdrawal after he was born. Pediatrician, on the other hand, reported that there was, in fact, a plan of withdrawal. So again, lots of contradictory information. All the information we got initially was from the father and the grandmother, because the mom didn't attend the first appointment with John. So dad reported also that he found out following the birth that that apparently there was a co-twin who didn't develop and didn't survive and had died in utero. Shortly after he was born, John developed jaundice. He received phototherapy, which led to what is described as distress in his chart, and he was admitted to the NICU for a day or two. And then he was eventually, after about a week, was discharged home to his mother and father's care, actually, with monitoring by the CAS due to a history of both parents' history of drug abuse, and mom in particular history of intravenous drug use. So when we met with the grandmother the first time, she reported that she always had concerns about the ability of her son and John's mother to look after him. She noted that what she described was that the mother seemed to have very little interest in having a child at the time that John was born, and also that she was smoking marijuana regularly, and there was a lot of what she called drug-related activity going on in the house. John's father also said when we saw him that he was not what he described as not necessarily eager to have a child, and felt he really didn't know what he was supposed to do as a father, and so left the child care up to other people. So he stayed with his parents for a few years anyway, but they could have ongoing significant substance abuse, and there were other illegal activities going on. And to the best of my knowledge, Mom continued to use intravenous opiates. So there were reports that the mother had, so she has another son by a previous relationship. She had been taking his stimulant medication and selling it for money to buy other drugs. And when we first saw her, I went and Googled her name, and what reported was there were a number of charges over a period of several years for possession of narcotics for the purpose of selling it, possession of guns, selling illegal handguns, a variety of things that are not necessarily trivial. More concerning, I think, though, from our perspective, was the amount of what the neglect described. So the grandmother said that, in fact, when we first saw her, I think she said that she really wondered if the actual problem was neglect or abuse as opposed to anything else. And he had been at daycare. The daycare and the police were called multiple times. CAS had also been called. On one occasion, John was found outside walking along the sidewalk in winter wearing his pajamas and slippers only. Somebody called the police. I think somebody in the neighborhood knew where he lived, called the police. And when the police officers took John to his mother's house, she was fast asleep. And from what Dad says, may have been, I guess, nodding off of heroin or something like that. And she apparently didn't even realize that John was gone. And when the police officers came in and knocked on the door, she actually blamed it on an older sister who was living at the time, a half-sister. And she said that this 5-year-old girl was actually supposed to be watching John, and that it was her fault that he had gotten out of the house. It had nothing to do with her responsibility. So the other thing that the grandmother reported to us, not trying to make anybody sick, was that when he ate, he often seemed to just gorge himself and shoveled his food in his mouth, and she wondered about the amount of food he was being given and the quality of it that he was receiving also. So his speech was delayed in developing, and Mom said he attended a Tyke Talk, so a speech and language program, Meow, here in London, but his father and grandmother said he had never seen a speech pathologist. Grandmother reported that he was toilet trained, but then in the summer prior to assessment, when Dad moved out and grandmother was seeing him less, that he was put back in diapers, and she reported it was because she thought that Mom just couldn't be bothered to take him to the toilet or wasn't able to. So John's parents had lived together until about 6 months prior to the appointment when Dad moved out and moved in to live with his own mother, so John's grandmother. Initially, the parents agreed that John would stay with Mom and visit Dad and Grandma on weekends. A couple of months prior to our seeing him for the first time, the Children's Aid Society became involved due to concerns about neglect raised by neighbors and other people around, including daycare, and also what was described as a mother's insufficient housing. I'm not sure what that means, and it was never defined more than that. So the CAS became involved, and Mom agreed to have Dad and to have John live with Dad and grandmother, but they also remained involved because they had concerns about this placement, as a lot of what they described as threats and spanking were used in order to get compliance. So let me just stop there. I mean, Joan, is there anything else you want to say about what we know about this young boy?
No, I think you've covered most of it. I think the only thing I would add is that, Grandma plays a big role in here, and we've talked about her and her identifying her concerns. But when we talk later about sort of the chaos of the appointments and stuff, Grandma was sort of part of that chaos rather than being maybe as stable and steady as she appears from these slides. So Grandma was certainly involved, and out of Grandma, Mom, and Dad, I think she was probably the most stable, but I think she herself had her own issues.
Some of which may have been cognitive. So at our first appointment, she was talking about taking John for a haircut, and I suggested that male pattern baldness was a really popular look among kids nowadays. And she actually looked perplexed, as though she wasn't sure whether she should believe it or not, whether it was a real thing or not, as opposed to telling me that obviously that's the stupidest thing she'd heard. Anybody have any questions or comments? So Jeff, St. Pierre, earlier I saw that you had typed in your name. Was that
He wanted us to know he was here.
because you wanted to ask questions? Okay, well, greetings. And I think everybody is unmuted. Let me see here. Sorry? Yeah, if I was going to, yeah, so this is the first time I've ever run anything on Zoom, and much like Ted Stevens' difficulty understanding the internets and the series of tubes that is the internet, I don't claim to have any direct knowledge or expertise. But Sarah O'Flanagan, who typically would be running this, isn't with us right now. Can I assume there's no questions then? Joan, what do you think?
I think now we can move on to the next part.
Okay, that way I don't have to be responsible if anybody's upset. Okay, so, oh, hang on, something's flashing here. It says chat. Had he always been in his parents' care? Hi, Jackie. So yes, he had, up until just before we saw him, and we'll come back to that in a moment. So he'd always been living with his parents. His father had moved out to live with his own mother about 4 or 5 months before we saw him. Other than that, he'd always been with him, at least to the best of my knowledge. There were no reports from anybody that he wasn't living, that he had moved out, or sorry, that he wasn't living with his parents.
And so I think living with his parents was described to us as he was in his mom's care most of the time. That dad was out of the house most of the time at work. So theoretically they lived together and they were parenting him together, but I don't think dad was there much.
So Jackie, just with your thing, your comment about the muting. So I think I've unmuted everybody to the best of my knowledge. I will try again. All participants are unmuted, it says now. So apologize if that was not the case a moment ago, although I thought it was.
And he didn't go to
There's about
daycare.
1,000 different things. For me?
And he didn't go to daycare.
Well, I might have put down he would because I try to anonymize things, but apparently that's not something you're in favor of.
I think it has relevance in that there were no other caregivers involved for this.
Fair enough, yep. But yeah, the I think they might have talked about wanting to or something like that, but okay, so this is from the famous Michael Scott of Dunder Mifflin fame, reports that even if everybody is unmuted, they have to manually unmute themselves from their own computer as well to be heard. And with making something that simple, what else could go wrong if everybody has to do something different? But thank you, Michael. That's really appreciated. Now, so if we go back to our patient, so we had a long history of significant behavior problems. If he had gone to daycare, there would have been a history of significant behavior problems, but certainly in school. So in junior kindergarten, the year before we saw him, he was only going to school for 1 hour a day because of difficulties. And in grade 2, when we saw him, he was attending for only 2 hours a day. What was quite impressive in looking back at his report cards the other day, and I hadn't realized it at the time, was that he actually, I think through the end of his junior kindergarten year, it indicated he basically had not missed any days of school, which I'm not sure how that's even possible, frankly, knowing his family. But he was only going for an hour a day in JK, and now, in grade 2, I should say, in senior kindergarten, my apologies, he was staying for only 2 hours a day. And the school reported really significant concerns for his safety as well as safety of others. He would run away from adults, he would climb on desks, he needed constant supervision, otherwise he was incredibly disruptive. And as an adult, whenever they would leave the classroom to walk down the hall, somebody had to hold his hands, otherwise he would be gone. And so even at recess, he needed constant, very close supervision. So we had the teacher complete the SNAP, which is Swanson, Nolan, and Pellin rating scale for attention deficit hyperactivity disorder symptoms. And his scores were elevated for inattention, for hyperactivity, and oppositional behavior, but neither parent returned the copy of the form that we gave them.
So somebody's not on mute.
So, yeah.
Do you want to remute everybody?
I don't want to be that fascist personally, and now it's stopped. So there we go. Okay. So the school also reported that he needed constant supervision when he was eating, because he would just stuff as much food into his mouth as possible, and they were actually quite concerned about him choking. This was one of the things that had led the grandmother earlier to wonder about how much food he was being given at home, actually. The school also reported a lot of problems with oppositional behavior and defiant behavior, and really significant problems with emotional regulation. He became agitated if anybody entered his personal space, or touched the toys he was playing with. When he was upset, he would throw himself to the ground, he would yell, he would scream, he would throw things around the class, he would hit and punch other people and bite other people also. The class had to be evacuated a number of times because of this behavior, and he was also sent home a number of times in JK. And although we saw him in October and November of his senior kindergarten year, he'd already been sent home a few times. The school also noted that when he was really excited, he would flap his hands and at times would hit himself. So seemed to have difficulty regulating any kind of significant emotion. So because of these concerns the school had raised and because of concerns his mother had, she had asked a pediatrician about a referral for a question of autism. So Dr. McLean had asked how much contact did he have with his grandmother prior to that. So he was seeing his grandmother a couple of times a week. She actually tried to make it, or wanted to make it more, because she was so concerned about the quality of the care that he was receiving with his biological mom and dad. I'm just not so sure how available they were to even schedule things like that. And so with regards to sort of possible symptoms of autism, so the school reported that he played alone. He didn't initiate interactions with peers. They didn't initiate any interactions with him either, which could be related to his aggressive behavior. His eye contact was limited. He didn't use many facial expressions. He would use phrases that he had learned from television or watching YouTube videos, but they seemed out of context and unrelated to what was going on. He also played in the same way over and over by lining toys up, and it seemed almost as though there was a note from the school that everything had to be done in the exact same way when he played, that it had to follow a very specific rule. If anybody was playing with him and they didn't follow that rule, he became quite agitated. He was also bothered by loud noises and often retreated to the cloakroom if the class was too easy. He would take himself to the cloakroom. So question about genetic testing, it hadn't been done, and in fact, medical care that may have been necessary was not necessarily followed up on. So I think, frankly, from his pediatrician's perspective, genetics testing might not have been a real priority, given that a couple other medical problems he had. Right. So after the referral was received here at CPRI, Kayla Cummings, our care manager, had put a note on his chart that she attempted to call mom numerous times in order to talk to her about setting up an appointment. And it probably took 3 or 4 weeks before she was even able to talk to the mom. That mom missed she reported her phone had been stolen, that she had called and left a message at one point saying, you can call me at this time. Kayla wrote she had tried her like 7 times in the space of 3 hours, and there was no answer. So it was difficult to get to reach her to set up an appointment. And when we were first received the referral, I think the parents were still living together at that point. It was just shortly before Dad, or shortly after. And so he came to his first appointment with his father and his grandmother. Mom came to the second appointment with a social worker for the Children's Aid Society. And something that happened then, and it's an ongoing problem today. We had talked to the CAS worker about trying to get some document outlining custody, given that he was living with his father, but his mom said she was still the guardian. And the letter we got from the CAS literally said, it's our understanding that John has been residing with you since September. As per his school schedule, he needs to be taken to school for 9 a.m. and picked up at 11 a.m. So it really said nothing of any value in terms of what his legal standing was regarding who was his guardian and things like that. Okay, let me just stop there for a second. Anybody want to ask anything further about him? Joan, anything else you want to add about his history?
No, I think you've covered most of what we knew about him at the time.
But?
I was just thinking my wheels are turning, but I can't think of anything that you've missed. You've done a good job.
Oh, thank you. A plus.
What were the parents' diagnosis?
So I'll come back to it in a second about the family history. So just in terms of his medical history, so he had been born with a murmur. It sounds like it was probably benign. According to the father, that John was supposed to be seen by a cardiologist at 1 year of age. but Dad wasn't sure if that had actually happened. His father also reported he had asthma, and that in the past he'd have to visit the emergency room, not regularly, but not infrequently, in order to get nebulized salbutamol, especially if he had any kind of respiratory tract infection. But at the time that we saw him, he didn't have any prescriptions for any medicine or any inhaled medications, and hadn't been to the emergency room for over a year. So Dr. McLean was asking about his language. So we actually were able to get a language assessment done, and Joan's going to talk about that in a moment. So there were no history of hospitalizations, no operations, never had any seizures, he had no allergies, and his father didn't know if his hearing had been tested or not. So a lot of unknowns. So in terms of the family history that you're asking about, Joan, so their parents were not related to each other in any kind of way. Mom died in miscarriages. So he has no full siblings, John, but there are 2 older half siblings, both by mother, and those 2 siblings are half siblings to each other. So 3 half siblings essentially. And neither of those 2 other children lived with their mother. One who was, I think, 13 or 14 when we saw John, had been diagnosed with attention deficit hyperactivity disorder. So that's the one whose the mother had been selling the stimulants to get money for opiates. But apparently at the age of 13, it was reported that he was smoking marijuana on a regular basis already. John's father reported he had what he called behavior issues starting in grade 5 or 6 with anger management problems and frequent fights. He also said that he had been an A or B student in school, and that he never had any problems in school, that he wasn't any special education or any special support, and that he had never had an individualized education plan. I didn't know him when he was in high school, but having met him, that would surprise me, I suppose, would be the polite way to say it. Joan, is that an idiosyncratic opinion?
No, I think that certainly there were concerns about his information processing skills and maybe the speed at which he could handle information and the quantity and quality of information he could handle as well. So it was sort of global concerns about him.
And beyond, and we actually knew very little about Mom, other than she had a history of significant substance use as they died. A paternal cousin had a history of significant behavior problems with emotional regulation and anger management, but apparently that was getting better. And so that is sort of what we know about him in terms of his early development and his social background, things like that. Before we then move into what we actually did with him, any questions or comments? Jennifer, when you were asking about his speech and language assessment, was there anything in particular you wanted to know?
So I'll just maybe speak to Dr. McLean's question in terms of sort of the presentation, John, at the beginning. So John came to us, he certainly was using spoken language. At the time, he used words and put words together in phrases. There were grammatical errors that were evident in his utterances, but certainly he was able to indicate sort of what he wanted and what he didn't want. His receptive language was a little bit harder to figure out because his attentiveness to language was very poor. So there were often times when he didn't respond to anything that was said to him or respond to his name being called. But if you gave him simple language and paired it with a gesture and it was something about which he was interested or motivated, he usually followed instructions that were simple. So at the time, certainly he, verbal communication was his primary modality of interacting, and he was able to do that adequately, if not sort of at the level we would expect for his chronological age.
And Joan, given what we'll talk about in a minute with his behavior, how difficult was it to do an assessment with him?
So we tried to complete an assessment with him on both the first and second appointment days. On the first date, he was accompanied by his dad, his aunt, and his grandmother. And he sat for a few minutes, but we weren't able to complete anything. The second day he came, he was only with his dad and his grandma, and his behavior was sort of out of control that day, that he did not sit, he did not attend, and it was really rough to watch his dad trying to manage him. It became pretty physical and it was pretty uncomfortable. So he was not able to sit and do anything in terms of standardized testing at that point in time when we first saw him on either of those 2 appointment dates. He did a little.
We haven't done any. So we haven't been able to do any language testing since then, have we?
Yeah, we did. So this was the first time we saw him when he was 5. We didn't really get anything that was particularly meaningful, but we have since seen him and have a little bit more information. Do you want me to talk about that now or later?
What would you like to do?
Well, I think that there's a story that goes with John about sort of him getting some security in his placement. Are you going to talk about that? Because I think we see a different skill set to some extent now.
And I think he also received superior psychiatric care.
Well,
so Jennifer is asking what was the quality of his communication?
so the quality of his communication was inconsistent. He was inconsistently responsive to other people's bids for his attention. He was intrusive in his own communication. If he wanted something, he wanted it now. He was loud. He did not use a lot of conventional gestures, but he certainly used physical actions. So at one point in time, he wanted Dr. Nicolson to eat a piece of toy pizza, and he sort of stuffed it toward his mouth. So he was pretty aggressive in his actions, but didn't have a lot of the social nuances that maybe would be expected. So yeah, his quality was concerning, to say the least.
So the other thing is, sorry, I should have said it earlier, and Michael Scott just reminded me, anybody who would like credit with an accrediting body, so College of Family Physicians or College of, or the Royal College of Physicians and Surgeons, or speech and language people, or psychologists, or the CBAs, although I don't know if we have accreditation with them. Just when you log in, you had an email, but they're not always obvious as to who it's from. So if you didn't actually use your real name, please go back and do so if you need credit, if you would like it. So Jackie also was asking how often had he been seen by physicians. I'm not sure, Jackie. It's not clear what his early milestones were like. And he had been seeing pediatrician with his son as a dermatologist, and I think that pediatrician had tried to reach out, but just wasn't really able to see them regularly. And so it's not clear. His grandmother didn't give a, dad wasn't really able to comment upon his early milestones. Pediatrician, grandmother didn't seem to think they were behind significantly, although but I think actually his speech was behind at one point in time. So otherwise, I assume he wouldn't have been referred to type talk. And so, there must have been something. So again, it's inconsistency in the story we get. Sybil, in terms about his growth and his weight, no, not particularly. When we saw him, he was a reasonably sized kid for his age.
He did also, I should just add, he was a little bit echolalic in response to Dr. McLean's question, that he did repeat words and some phrases as well.
So when we saw him the first time, so he weighed 27 kilograms with a height 116 centimeters, which are reasonable for somebody of his age. The nursing staff was not able to get blood pressure, heart rate, or his head circumference. Didn't have any dysmorphic features. There were no abnormal involuntary movements, and there were no tics either. So when we saw him the first time, he initially sort of made reasonable eye contact briefly. However, he was really impulsive and lacked understanding of boundaries. So as Joan said, he walked in, and I've got some pretend food in my office for people to play with. Pizza, or maybe it's quiche, but it's about an inch thick, and it's solid plastic. And he walked up to me and jammed it into my mouth, and I tried to. I think he might have chipped a tooth if I hadn't sort of blocked him. And then he immediately sat on my lap, which I try not to acknowledge in case the college people are listening. And he sort of stared into my eyes closely. He then wandered off and later came back and sat down on my lap again. Although I will take it as a compliment that he sat on my lap and not Ms. Gardiner's. But then we saw more problems. So he asked to draw a picture, which was fine, and I gave him about 10 crayons, I think. But there was like a bag of 200, and he wanted all of them, and he began to grab at it, and he yelled and screamed. Whenever he wanted help with something, if he didn't get it immediately, he would sort of just start just firing the word help at people, and became more and more frantic sounding. At one point, he asked his grandmother for a snack. She peeled a banana and gave it to him, and he shoved all of it into his mouth almost at once, and then sort of began to run around the room. He moved constantly. He wasn't able to sit and focus on anything, and he was, as I said, really intrusive and really loud. Came back a few weeks later, and Joan will talk about the Autism Diagnostic Observation Schedule at that point. But anyway, at that appointment, he immediately took off his socks and shoes, stood on a table, and then stood, and from the table, used that to stand on a cupboard, the room that the cupboard is in. So the cupboard's about 4 or 5 feet off the floor, and it sort of runs the width of the room. Neither parent said anything to him about getting down. They just sort of left him there. So I, in my infinite wisdom, walked over and asked me to get down. He didn't, so I went to pick him up, and he scratched me across the top of my head. And Joan, I think you said there was a fleeting glimpse of anger that you've never seen.
I have never seen you look quite that angry in that moment, but you held it together. I don't think that they knew you were angry.
Well, it's the value of impulse control, I suppose. But so he climbed on a couch. He jumped off it repeatedly. When his mother told him to get down, he yelled and began to swear at her. And then I think she gave up. And as Joan was saying, and watching the dad try to control his behavior, I think it was the same with mom, that he was pretty much out of control. And when he asked for things, if he didn't get them, he would yell loudly, begin to scream at people. Although he had some problems with using communicative language in a way that we would like, he certainly had some very clear choice words for other people. I think he may have been directing them. Said wasn't directly directed at anybody in particular. May have been to Joan, but I'm not sure. But I mean, he really was wild and incredibly difficult to manage. So at that point in time, we because the question was around autism, and certainly he had a lot of behaviors that were concerning and socially difficult. So we did the autism diagnostic observation schedule, so that's structured, semi-structured instrument to look for behaviors. Joan, do you want to briefly describe what we saw?
So when we did the ADOS with him, he certainly engaged in a way that we were able to score it and felt that we could administer all of the different activities. And there was quite a profile of concern that emerged from it. There were certainly some strengths as well. But if we talk about the strengths, so, his language was okay. And we talked about that earlier. And then it was, mostly creative. It had its grammatical errors, but it wasn't super scripted or anything concerning that way. He did respond when we called him by name. And he did do some showing of some of the toys and activities to the other people in the room. But in terms of the concerns, again, his volume was odd in that he was very loud. He did not participate in any sort of conversation or reciprocal sharing back and forth play with other people. He didn't point, he didn't use gestures. His eye contact was poor. He didn't use a lot of facial expressions, and it was really on his own agenda. So he played with what he was interested in, and his attention was short and fleeting, so that changed quickly, but he really couldn't sustain play and didn't share his play with other people, I think in part because he was just moving so quickly from one thing to the next. He didn't make a lot of overtures toward other people, didn't invite other people to play with him. He did use toys appropriately in terms of what they were supposed to be used for, but there was a little bit of some sensory sort of repetitive play. He liked the fan on the bubble wand and things like that as well. So when we scored the ADOS for John, there were a number of things that scored high, and in his overall score, it certainly did put him within the autism range with a comparison score of 10. So very, very high in terms of how he looked on that particular protocol.
And so this is where Joan and I have talked about John several times over the last few years because we continue to see him. And so before I say anything further, actually, does anybody want to offer up some ideas about what we might want to consider in terms of a diagnosis for him? Let me see. If people want to unmute themselves and say something, that'd be great, or nothing, I guess.
Well, Dr. Pryor's weighing in.
With an excellent suggestion that some people might be more prone to agree with.
So Dr. Pryor, for anyone who can't see, is suggesting the possibility of attachment. It's associated with a strong prenatal history of drug use and neglect. And also the
So Paula Walshbergen has wondered about genetic abnormalities. Certainly something that we want to wonder about. Sorry, somebody else I think waved at me or raised their hand. I'm not sure what the term is, and I missed that. Jeff said he wanted about trauma. I guess, Jeff, the question in my mind would be, trauma is something that happens, it's not really a diagnosis. And I understand that diagnoses don't explain everything in psychiatry and psychology, and maybe shouldn't, but just in terms of, people are asking what's wrong with him, what can we do? And we know services depend upon it. So the question we really have is what the diagnosis is. Now, Carla has raised her hand, and I don't know what to do besides wave back. Carla, can you unmute yourself. Oh, hang on, I'll unmute everybody again. Everybody is unmuted now. If you want to ask Carla directly. It keeps telling me to unmute people. So it says everybody's unmuted, and then it says I have to unmute everybody. So that's a like a Zen code. I guess, Carla, it might be easier than if you want to type that. Sure, actually, Carla, you haven't had to worry about not hearing questions because nobody's asked any out loud.
But she can type her questions.
Yes,
I understand
there's questions coming from different forms also.
Bradley.
Dr. Bradley wondered about sort of chronic autonomic nervous system arousal. And, that's an interesting point. I have, there's a girl I see who actually was raised in a Bulgarian orphanage. And very similar, I think, the difficulties. And she is one of the oddest people I've ever met, I think. And we see a lot of unusual kids, and she is very different. One of the first times she met me, she actually walked into my office, looked at her mother, pointed at me and said, "It's bald." So not he's bald, which would still be inappropriate, but it's bald. But she just strikes me as somebody who's just constantly over aroused. And I often wonder if there was some kind of cortisol blocker that didn't have other problems, would that be the best treatment for her, really? Let me see here. And Dr. McKinnon. So Kathy, we suggested hearing it wasn't followed through on, and Dad wasn't aware whether or not hearing testing had been done. And Dr. Bradley, we don't know. There had not been a sensory assessment, and outside of parents filling out rating scales like with the sensory profile, I'm not sure anybody would have been able to do. At least when we first met him, I don't think anybody would have been able to do an assessment with him.
I think we can say though, and I know we're getting short on time, so I didn't know if we were going to talk about sort of his, current situation, but he has moved to a different placement, and we were able to do some language.
Yes, come back 1 sec.
Okay.
So so in terms of diagnostic possibilities, and actually I don't know where this came from. Nobody suggested social syndrome for him. So what we thought about for I have no idea what happened to my slide. So like this again, it's mostly the people from the Q group. So what we have debated about, does he have autism, or does he have what Rudder and his group would have called quasi-autistic features? And so does he have autism, or is it really due to an attachment disorder? That I think pretty clearly, I think at least on a purely overt behavioral basis, I think we could say he has attention deficit hyperactivity disorder. Maybe due to different causes, but I think there's no doubt he's overactive and inattentive. And I suspect he has an intellectual disability as well. So as Joan said, we've followed up with them since then, and I'm not sure what happened to my slides here actually, but when we gave them feedback that we weren't exactly sure his diagnosis, but these were our thoughts, started him on risperidone, came back a few months later with Dad and CS worker, and Dad reported there had been a significant improvement in his behavior, that he had actually started wetting the bed after starting on it, but school and Dad both reported there was less aggressive behavior, there was less outbursts, he was less impulsive. And so said, that's great. Next time we saw him, he had actually moved in with an aunt and uncle. And given everything else in his family, it's surprising to me how together his aunt has her stuff, that it's quite remarkable, frankly. And really what they've provided him with is stability, consistency, clear expectations and things. And they've done a wonderful job. When we saw him the next time, so this was only 3 or 4 months after our previous one, maybe 6 months from the time we had seen him, the first time he had moved to a new school and was now actually going to school full days. And he made real gains there. This past December, we saw him, and so we've seen him as time has gone on. Saw him in December, started him on lisdexamfetamine or Vyvanse for his inattention hyperactivity. And when I spoke with his aunt in late March, she reported that it had made a significant difference as well. Again, ongoing, really significant problems, but with the combination of risperidone and Vyvanse, there had been an improvement. One thing we're stuck with regards to John, and it's not directly relevant, but unfortunately, the CAS is no longer involved at all, and he hasn't seen either of his biological parents for over a year, and the only thing is aunt and uncle have, again, just states that he is now residing with his aunt and uncle. So they actually have no legal standing whatsoever. And it's actually created an issue with us in terms of assessments and what we have consent to do. And we've tried to get some information from the CAS, and they really, I don't want to say they haven't been helpful, but they haven't been forthcoming, I suppose. Is that fair to say, Joan?
Mm-hmm.
And so they're in a legal limbo, essentially. So we saw him in December before he actually started taking the Vyvanse. Because of the ongoing question of, does he have autism? What else is going on? We had seen him again to do the ADOS again. Joan, was it any different this time?
So it was different. I mean, he still had a profile of strengths and concerns, and the concerns still outweighed the strengths. I think his overall score at the second time that we did it still put him within an autism range. His strengths, though, sort of from a qualitative perspective, were encouraging. So he was using language more creatively. He was responding more consistently to his name. He was doing some showing and inviting other people to engage in shared activities. His play looked a little bit more functional, a little more creative, and a little less demanding. And there was no evidence of any restricted or repetitive patterns of behavior or sensory interests. And that was a change for him. So that was really nice to see. He still didn't have very good conversation skills. He still wasn't using a lot of nonverbal forms of communication, including poor eye contact, limited gestures. And he didn't make a lot of social overtures, so he invited people to play with him, but other than that, he didn't have a great repertoire. And he was still relatively inattentive compared to what we would expect for his age. It was a nice improvement for him, but still concerning relative to what he would be expected to do in a typically developing classroom. So his score, comparison score on the Autism Diagnostic Observation Schedule, the second time we saw him was a 7 rather than a 10. So still within the autism range, but less qualitatively concerning.
And so we continue to disagree. I'm not sure what happened to my slides. As I say, the final slide I was going to have was around differential diagnosis. So I believe he almost certainly has an intellectual disability. One issue that we have is because we would like to do some cognitive testing, is figuring out who can actually provide consent for that. And I think we can say, at least on a behavioral basis, he clearly has attention deficit hyperactivity disorder. One of the two of us believes he has autism. I would personally say he has quasi-autistic features. And actually with the slide, which I don't seem to have, maybe Joan stole it, it actually said something about, in brackets, autism is possible, but probably not. And we shouldn't believe what the current member of CASLPO has to say about that.
What's interesting about him is that he has been in a home that has been stable, that has typical peer role models, and that he has 2 cousins. He is fed, they have routine, he is in school, and yet not everything is better. And it's still far from where we would want it to be and far from good and easy. So I think the fact that difficulties persist is concerning. I think intellectual disability remains unknown. We have got the referral in for psychology, but I don't see him as a typical ID type kid, and so what else is there?
So when you say you don't see him as a typical ID kid, what do you mean?
I think that his social difficulties are not accounted for by a diagnosis of intellectual disability. He is not performing simply like a chronologically younger child. I think qualitatively there are still issues around his intrusiveness, his play, his lack of learning and imitating from others, the way he does or doesn't even interact with other people, the inconsistency in his responsiveness. So,
but Joan, when you say that you don't think he's like a typical ID child, but do you doubt that he has an intellectual disability?
I don't doubt that he has an intellectual disability, and what we do know from the language testing that we were able to complete when he was with his current guardian is that his language scores, receptive language, came out at a standard score of 64. So that would be certainly below the age, below what we would expect for his age. It was a chronological age equivalent of 4 years at his actual age of about 7 years, 2 months. So certainly significantly behind in terms of language, and I would think that that is probably reflective of his more global profile as well.
And so I think this is what Ryder and his group would call were describing sort of the quasi-autistic features. I don't think there's any doubt that he has some autistic features that we might see in people with autism. Yes, the question is, how much do we explain that by early deprivation and lack of appropriate role models and interactions? And the same would go with language, that he, in order to be socialized, you have to have models for that. clearly he didn't have the same kind of deprivation as people in Romania did, but at the same time, if he was not being cared for appropriately provided and interactions, how much do we account for his difficulty with that? And so in theory, over time, if it is in fact an early neglect, let's say, I would expect that it should improve somewhat, but it's not a one-to-one correspondence that when he is 14, when he's 10, and he would have been with his aunt and uncle for 5 years at that point. I'm not sure if we can say that that makes up for the first 5 years of his life.
And so Dr. McLean is just asking how long he's been in the stable situation. So he went into the stable situation at about the age of 5.5, and now
it was a spring. It's a little over a year right now. And to give his aunt and uncle credit, he's a difficult kid. I'm really impressed at how they stepped up and took him in. And beyond that, again, given the chaotic nature of everybody else in the family, how well they have their shit together, frankly, I don't know how that's possible.
Yeah, because somebody else asked if he had ongoing involvement with grandma, and I think he does still have ongoing involvement with grandma. I think grandma sort of provides respite for the aunt, but I don't know that grandma is on the stable side of the equation in terms of his family members. I think she was able to keep him safe and probably not too much more.
No, so so Dr. Frid is asking, does he meet the criteria that Section 8? So, I mean, certainly he doesn't have appropriate, developmentally or chronologically appropriate social interactions. I think we can say that for sure. And he has abnormalities of communication, and probably has, let's say he has difficulties with social reciprocity. So yes, I mean, I'm not necessarily arguing that he doesn't meet the criteria for autism spectrum disorder. I assume he does, but I'm not sure that's really what it is. It's sort of like there was another boy we had talked about presenting if we had time, who we saw in the winter. And it was a very similar thing, except it seems to me with that other boy, Joan, that his presentation at both of our appointments was quite different.
I don't know that I would say it was different. I think what was really interesting about the other boy is that he was raised with siblings who didn't have the same types of difficulties that he had. So other kids who were exposed to the same sort of neglectful and concerning environment, but looked very different than he did.
All right.
So, the problem with John is that we don't really have a comparison. He is the only child from this particular situation in this particular context. So we don't know whether he would look the same if there had been more than him. Would there be other kids that look similar, or would those other kids look different?
Yeah. So Jackie Ogilvie made a good point just now. That is it possible that early difficulty and the lack of appropriate role models and nurturance, that with that plus his intellectual disability, could that, like, how much does that account for? Or if he's got intellectual disability and what presents as ADHD, would that take long? And I think these are all unknown questions. That I think that if his aunt said to me, look, well, I don't want to say it's probably, if he needed a diagnosis, I have no doubt that he meets the criteria for autism spectrum disorder. I just don't know if that's really what his problem is. And maybe that's more of an academic question as opposed to a clinical one. The other question Jackie asked was about, did his eating behavior change in living with the aunt? And you know what? I don't know the answer to that. That's a great question. I'll have to remember to ask them that. I don't think they said anything about that, did they, Joan?
I don't remember, but again, I'd be interested to know the answer, because did it change in that food was more available to him consistently? I know his grandmother had concerns that his mother had been feeding him rotten food, and that was some of the issue. Or did it just change because behaviorally they've got different expectations on him? So I think we should certainly ask, because it'd be interesting to know, but I'm not even sure that we could make sense of the answer.
Right. And Dr. Pryor was saying that many of the deficits he's showing now obviously could also be that the prenatal drug exposure could have an impact on that. And absolutely, and that's the thing, that it's there's so many different things going on with this young man, but genetically he's obviously predisposed to difficulties, and his early environment, both prenatally and postnatally, was less than ideal, to be frank. So how do we weigh those things against each other? And so I think that's a really great point, Catherine.
And I think what's interesting is Dr. St. Pierre has said here as well, he deserves a legal guardian. And I think, it's interesting because even that most basic expectation that this kiddo might have an identified legal guardian has remained unresolved for him, that they really haven't been able to fix that for him. So if we can't fix that, how else do we fix the rest of it?
Well, I would agree now that I think it'd be a huge problem if, if he needed surgery of some kind and his parents at best are unreliable and probably unreachable, and what would actually happen. And thankfully, that hasn't happened. And I think my guess would be that the CAS people cut ties because they don't have enough funding for things. And so if somebody else is going to look after them, they don't want to spend the money going to court, is my assumption. And so so Kayla Cummings has been in touch with the CAS worker. I can't recall exactly what happened, Joan, but I think the impression I had was that the CAS said they weren't really interested in doing anything further.
So the CAS provided a list of people who could stand in as legal guardians for this kiddo, and there's a list of sort of parent and grandparent, and I think his aunt and uncle who have him now would qualify under the number 8 of category of this long list that was any other family member. So it really doesn't identify them particularly as legal guardians. It just says that in the role of aunt and uncle, they would qualify given nobody else being available.
But so did they just copy what the act, like the consent act says? Like, did they literally just copy and say, here's the order of priority?
Yes, I believe so. It is not specific to John.
So that's completely useless?
Well, it's not useless in that I think it gives us a mandate that we can continue to provide service for him, because it says that under the act, there are people who can consent in this particular hierarchy. And so we have that going forward. But I think it really speaks to at a basic level, there is no identification of guardianship for this boy. How can we expect anything else to resolve other than he's got a wonderful aunt and uncle who, out of the kindness of their heart, have disrupted their entire family life to take in this boy.
But I think, though, that I think with the way the Consent Act works is you can only move down the list if you can't reach somebody else. And I don't know what effort is required to try and reach them and things like that. And it's just, it's problematic. And so one of the managers here has actually said that she would like to talk to CS. Unfortunately, the last time we talked about this was late March. And so right now we really can't do anything about it. Actually, thank you, Jeff. That's a great point. So Dr. McLean said that LHSC has free lawyer service for consultation. But I think for the aunt and uncle to go ahead and apply for guardianship, I would assume then the parents would have to say they don't want guardianship, or else I would think it would become fairly expensive. And when we saw mom the one time, I think she was, at least at the time, pretty clear that she hoped to get John back eventually. It was also the other odd thing about this case that I should have mentioned at the time was at our second point, when we met with mom for the first time, we were talking about things. The Children's Aid Society worker asked what I thought about physical discipline, or what we thought about physical discipline, and whether it was appropriate. And I wasn't sure if it was sort of like a candid camera or punk or something. I have no idea why somebody with CAS was asking that. It seems such a bizarre kind of question, given what they've said in the past about those kind of things to people.
So I'm just watching the time. I think at this point in time, what we can say is, meow, this little guy has consistent family home.
One.
What's that?
Exactly one.
1 minute left?
No, what you said.
He has a consistent family home. He has ongoing psychiatric care, who is monitoring him for the possibility of ASD or other things. He's got referrals in to investigate other diagnostic options. And he's got a really stable school placement with educators, other than, right now with COVID, but who are working with him and keeping him at school all day, every day. And I think
with the school that he's at, I think has a great reputation in terms of keeping kids there instead of sending them home and things like that. I was actually thinking, based upon what somebody had said earlier, maybe at some point in time, there's no urgency, but do we make a referral to an occupational therapist at any point?
I don't think we have. That question came up and I said, no, he hasn't seen an occupational therapist, but I think we should make a note of that for sure.
Yeah, I mean, that's certainly something we can get somebody to see. I think, unfortunately, with this young man, a lot of assessments are going to depend upon his willingness to participate in them at the time. So, all right, anybody else have any comments or questions, concerns, criticisms, meow, anything else?
Not sure, am I still on mute? Or can
you? No, you're not, Dr. Goldberg.
I think the two of you have made an excellent case for an attachment disorder, and particularly in terms of the maternal deprivation component. But the other thing is the prenatal drug exposure, which would have interfered with his survival instincts. And I think what protects a lot of children from maternal deprivation is their survival instincts, being able to smile, being able to reach out, that type of thing. So it's a combination. I think it's of an attachment disorder, plus I think and maternal deprivation, but I think the prenatal drug exposure must have had some influence on his survival instincts, which are probably still carrying on. Any comments about that?
I think that's a great point, Dr. Goldberg, but also it's development is an ongoing process. And so if there are early problems, that's going to affect the way his brain develops, which is going to make it, that sensory stuff may be much more overwhelming for him, which is going to affect his behavior, and it's going to cause ongoing difficulties like that. So I think that's a really good point. When you talk about survival instincts, and I'm not sure, I know what you mean exactly, but I think in terms of protective factors, now I might have I might have feelings because of the fact he might have almost chipped one of my teeth and scratched my head, but I'm not sure he is somebody that other people would find pleasant to be around, or at least when we first saw him wasn't. And I think that's going to create difficulties at the time anyway, because people wouldn't have wanted to do things for him if he needed extra help. And so he wasn't somebody who was outwardly pleasant that people would go out of their way to help. Is that a reasonable statement, Joan?
Yeah, I think you like this kid if you know his story, and you like this kid if you know his aunt and how much she's done for him. But I think for somebody who maybe doesn't have that context or background exposure, he's a lot of work. He's a really tough kid. He doesn't socially kind of give you back, which I think is why that question of autism persists. It's kind of about him. It's his own agenda. Reciprocity isn't great. Shared experiences aren't great. And so you have to work pretty hard.
It's interesting when you say what is likable about him is his aunt and his uncle and his history, which I suppose makes us feel sorry for him. Neither of those involves him directly in his presentation.
No, but he probably can't control any of the factors one way or the other. So
no, but I think it just becomes, and so he has limited social interactions, but I'm not sure other children are going to want to play with him. And unfortunately, I don't think other children's parents are going to invite him over for birthday parties and things like that because of his behavior.
Oh, thank you both.
Thank you, Dr. Goldberg.
Dr. Goldberg.